and but I have learned a little bit over the years, mainly from you probably, and Alex and people like Julie Lesk, who's been helping us. And it is nice to talk about something other than COVID for once. On the show, I'll just start by acknowledging that I'm presenting from the lands of the Bunurong and Boiwurrung people in the Eastern Kulin Nation here in Melbourne. So antibiotic stewardship. So this is really about the quality of use of antibiotics, and there's sort of criteria that are used to say, you know, what's appropriate. You know, narrow but not too narrow, targeted the likely pathogens. It's adjusted once you've got a diagnosis, or you've isolated a bacteria. The appropriate route, so oral or IV, as the case may be. It's given quickly enough, appropriate to the condition, and for long enough, but not too long. And obviously, there's a lot of, you can tell from that, there's a lot of subjectivity in some of those decisions. And just to say that in hospitals, it is a very different place to primary care. So often you're giving people that are very sick, you're trying to give antibiotics very quickly. Those decisions need to be made, and things that might work in other settings like shared decision making, just, you know, you can't really do that in hospitals in a lot of settings, not all the time, obviously, but at least in the emergency department, it often is quite difficult. And there's lots of excuses why people say that you know, things are inappropriate. There are lots of guidelines, but people don't use them. There is that sort of perception that I have a really sick patient, I'm just going to blast away with antibiotics and not have to, you know, take that out of the equation, even though they may not actually have an infection. There's all the sort of process issues about being really busy and not being able to look up results very quickly. There's, you know, people are just often remembering, you know, what they last gave, and maybe that dose isn't appropriate, or they forget to cross it out and the duration is too long. And then there is the sort of hierarchical structures of hospitals where, you know, someone senior just says, you know, I want you to give this antibiotic, and maybe junior doctors who may know better don't get the opportunity to challenge that. So a lot of what antibiotic stewardship is about feedback loops, and this is really a concept that's common to a lot of healthcare quality, and has been you know, used for antibiotic stewardship for quite some time. And there's lots of different levels that these feedback loops can go through. So I'm going to give you a lot of examples of how these work in the hospital setting. So the first is about how basically a hospital AMS program works in practice. And this is what we do at the Alfred Hospital. It's different in different hospitals. In the Alfred, we notice that we really have sort of three main groups of units: the really, really complicated patients, you know, transplants and intensive care. And it's very hard to just look at a chart and say, you know, this antibiotic is appropriate or not. It really often takes a discussion with the, you know, the treating clinician, and, you know, a sense of how they're doing, and these sorts of things. So that's not something that can be is amenable to a sort of a rapid assessment. So for that, the way that we've tried to approach that is to have routine ward rounds where there's an infectious diseases physician that's embedded on those units. At the other end of the scale is, you know, rehabilitation and geriatric care, where they aren't really on, not many antibiotics are used. They may not, the ones that are may not be used all that well, but it's not a high volume place. And then in the middle is sort of general medicine, and this would be sort of 3/4 of the hospital. Those sort of units where, you know, there's a lot of antibiotics used. They're relatively simple problems, so they can be assessed fairly quickly. And we do these, what we call antibiotic stewardship rounds, where we just go and look at the notes, just try and establish if it's appropriate or not. Have they actually checked, you know, the micro? And then we can make suggestions for the unit. And we measure sort of process measures on this. We can do, you know, maybe 100 to 300 of these a month, where we can just quickly flip through notes. It's much more easy now with electronic medical records. And we measure, we have process measures for this program. So, you know, how many people do we see? And then the sort of outcome measures, looking at quality indicators and outcome, the volume of antibiotics used and so on. And about 10 years ago, we looked at sort of the early outcomes from this, and this has been sort of sustained over a little while now. where by bringing in one of these programs, we could show that there was a decrease in the use of some broad spectrum antibiotic classes. So this is ceftriaxone and vancomycin particularly. But then we also had this problem of what's often been termed called squeezing the balloon. You sort of restrict antibiotics at one end, but at the other end, they use something else and it may not be all that great what the alternatives are. So this is piperacillin tazobactam, which did increase during that time. But overall, if you sort of put it all together, it looked like there was an impact. And in fact, there was an impact not only on broad spectrum antibiotics, which we were targeting, but actually on narrow spectrum antibiotics as well. So I think the consciousness that we were looking at them and that people were stopping those antibiotics was evident over time. The second example is what we've done more recently, which is a sepsis program. And this sepsis is basically severe infection, has a high mortality. It is one of those things, unfortunately. I think, the analogy is pornography. It's something that you know what it is when you look at it, but you can't really sort of define it. And there's a lot of diagnostic uncertainty. So when a person walks through the door with a severe infection, they don't come in with a sticker saying, I have a severe infection or I have sepsis. They often just look sick, and you often don't know where it is, at least within the first hour. It's you may know, but it's sometimes very difficult to work out where that infection is coming from. But what is known is that there is a strong correlation between how the patient does and how quickly they get treatment, and particularly antibiotics. So this concept of a sepsis bundle, where you've got to give 3 things and take 3 things, is sort of quite embedded in hospital education programs at the moment. And so this is sort of how we're doing. So there are 2 groups of these: the emergency department, where the patient walks through the front door with severe infection, and where there's delays, it's I didn't realize that they were quite that sick, or we couldn't get them into a room in time, or we just had no idea what was going on. They were just sick. And so there's a lot of education and trying to set up systems to get sick people into rooms quickly and get them identified early at triage. And then we found that having a pharmacist involved was quite helpful. And then also having this concept of a sepsis call, hitting the big red button to get everyone responding to an emergency. In the ward, it's a little bit different. So people can get sick. They didn't come in with an infection, but then they get an infection or become their infection gets worse while they're in hospital. And so the way we've tried to define this is to link it to medical emergency team calls, so MET calls, code blues. And the delay's a little bit different there. Often they are already on antibiotics, but there needs to be a frame shift in sort of the thinking about, is that antibiotic correct? Was the diagnosis that I originally made correct? And that can be often quite difficult. But the big group that we've been able to address in there is communication. So the outcome of the team is saying, I want to change the antibiotics, but then someone forgets to tell the nurse, and then they don't give it for 4 hours or more. So there's a lot of trying to identify roles and standardized responses and so on to try and make sure that people know what they need to be doing. Then the other side of that, so you can see that there's a tension between giving antibiotics quick and early to anyone who looks sick, and then the appropriateness of that down the track. So the best way to sort of think about this is just, to start hard and then try to ease off early as soon as when there's a bit more information known. And so we did a small randomized controlled trial where we got the antibiotic stewardship team to see all the people that had a sepsis call to see if we could get them off antibiotics, and we're able to show that that we were able to do that in a significant proportion of people. Then the next feedback loop is how the Victorian control program for carbapenem-resistant bacterialis is working at the moment. So this is a very resistant gram-negative organism that unfortunately is becoming a bit more common in Australia. And this system sort of works by reviewing patients, and there's a lot of genomic information in this, so it's very complex information to put together. And not only do you have to work out sort of what genomic types there are, but also where has the patient been? Have they trying to track them through different hospitals is often quite difficult. And so normally a system would work that you'd find these cases of something bad going on. The hospital lab will tell the hospital infection control unit there's something bad going on, and then they would respond. And that's a very local feedback loop. But what this system adds to that is really someone that looks over all of that, and that's the hospital lab's able to feed isolates up to the state reference labs, and then the state reference lab is able to put it together with, for example, isolates that might come from different hospitals or from different labs. And then that's all put together at the state level, at an epidemiological level. And then there's a Victorian incident management team that sort of oversees the response to that. So that's the idea, is that the hospital infection control units are doing the responding, but someone is looking over their shoulder to make sure that they're doing what they're saying, what's meant to be happening. And some hospitals need more help than others, but in the end, we sort of know that it's been done. And then finally, the last loop is about how national surveillance and reporting is working. And there's what's called the AURA program, the antibiotic use, and actually I can't even remember what it stands for, but there's two parts of this. Is about hospital antibiotic use and hospital antibiotic resistance, and there are elements of these different systems to measure different parts of this. So in terms of antibiotic use, we measure the amount of antibiotics that are used, as well as how appropriate that is. And then in terms of thinking about microbiological data, there are different sort of surveillance systems with strengths and weaknesses to try and get a picture of what's going on, particularly for key pathogens. So this is the antibiotic usage, or the volume of volume-based, and that's a system called NOUS, that's based in South Australia. And what you can see here first is that the bottom graph is really just principal referral hospitals. So this is big teaching hospitals. You can see there's quite a lot of variation, not only in that sort of red and yellow, so that orange color, and they're the sort of antibiotics that are regarded as fairly broad spectrum. And some of that is going to be explained by how acute those hospitals are, but a lot of it actually isn't, and there's quite a lot of that used. The top shows the diversity of all the different antibiotics that are used, and there's a lot of antibiotic categories. But what you can see is it hasn't really changed much, unfortunately, over at least the period of this report, and this is the most recent one. In terms of appropriateness, there's surveys that are done. I think it is always a little bit difficult to work out what these mean. They're often samples rather than sort of a full census. They're only taken on a couple of weeks of the year, so does it represent what's going on else other times? But despite all of that, there's quite a lot of data there, and again, it doesn't really show a huge amount of change in fact, if anything, it's probably a little bit worse. And you can see some of those reasons for inappropriateness on the right panel there. In terms of resistance, it's a very difficult data to sort of explain and convey to the public, but obviously, medical people that a bit more familiar with how to interpret them. But basically what you can see here is that there is, resistance to various antibiotics and it does vary in different parts of the country. One of the dangers with presenting this sort of data is that you get this sort of, what you can see at the bottom in the green is to say that there are very few of these E. coli that are resistant to carbapenems. So, some people will look at that and say, well, why don't I use that then for all my patients? But then it's a broad spectrum antibiotic and will result in additional resistance and cause problems and so on. And then these are MRSA and VRE isolates. Again, you can see there's quite a variation across the country. Victoria is a particular hotspot, but the Northern Territory for VRE is a particular problem. But you can also see that a lot of these are based on relatively small numbers, so it's very difficult to interpret these sometimes. In terms of how this is used, at the moment, the system isn't very well connected. So, the average clinician in a hospital probably wouldn't have any idea, unless they have a particular interest in looking that up. But in terms of public policy, there can be useful outcomes that come out of this. And I think this is probably the most successful example of how Australia has managed antibiotic use as an example of coordinated public policy. So fluoroquinolone is obviously very useful, but known to be susceptible to resistance. So there's a very low barrier to resistance. If you use it a lot, you get resistance very quickly. And there was a very conscious policy in the sort of 90s to not use it in food-producing animals, to follow the treatment guidelines, to not list it as first line therapy, which is unusual for most parts of the world. and then to back it up with restricted indication for subsidy by the PBS. So if you want to use ciprofloxacin, you have to call up someone and say why you're using it. And as a result, you can see on the right there that Australia uses very, very little fluoroquinolones and has quite low resistance. Obviously, it doesn't explain all the resistance, but particularly in comparison to European countries, we use very little fluoroquinolones. There is a national strategy. Again, most hospital clinicians probably wouldn't have much visibility of this. The second strategy has been updated recently. And there really does need to be some thinking about, how do we want the system to interact at a national level, and in terms of thinking about, how does the surveillance framework operate? So Phil Russo did this survey, really thinking about surveillance of hospital-acquired infection, but this is equally applicable to AMR and antibiotic use data to say, what are the things that we want out of all of this? So in conclusion, there's, there are sort of this top-down approach that's sort of running through that chain of governance, or things that are initiated from the bottom, and there are benefits to both. And what you want is a connected up system that has an appropriate governance structure. Most of the AMS programs have really been driven by clinicians working locally, and it's now sort of spread to, we have a national framework and a national program, but it is much weaker at the national level. But an example of where it has been successful is sort of having accreditation standards for hospitals, and that require having an antimicrobial stewardship program. Is obviously a major driver, particularly for smaller hospitals. And then we do have a national strategy in place. There's lots of work to do still in animal health and other, and trying to close those feedback loops. So I might stop there, but just thanks to quite a lot of people for all their input into our program at the Alfred.
Thank you.